Welcome to the first in a mini-series on ultrasonography of the GI tract. This presentation will describe the examination technique and describe and give examples of the normal sonographic appearance of the stomach and small and large intestine in the dog and the cat. After the presentation, you should be able to identify, distinguish between, and describe the normal appearance of the stomach, the small intestine, and the large intestine. And I want you to be able to describe and identify the individual layers of the intestinal wall. This presentation is going to give us the important foundation of normal that we need as we move into the next presentation and recognize the altered appearance in various disease states. Ultrasound is an important complementary diagnostic tool, but it should not replace survey abdominal radiography in the investigation of GI disease. And in some instances, other imaging options may be a better choice than ultrasound. Ultrasound has several advantages over survey radiography. It allows us to evaluate the wall and the lumen. It can also let us evaluate motility. In addition, once we identify a disease state, we can evaluate the extraintestinal or regional structures, which may help us with our differentials. And then we can guide sampling and maybe interventional procedures with ultrasound. Unfortunately, ultrasound does have limitations as well. Large patients can be quite technically challenging to image, especially if they are gassy. And large patients, we may actually want to consider doing a CT or an MRI so that we can see the entirety of the GI tract and the regional tissues. Lesion identification can be hit or miss. One, it's hard to follow the entirety of the GI tract from stomach to rectum. And then two, the various parts of the GI tract oftentimes have a lot of gas, and gas within the lumen will preclude us evaluating the rest of the lumen as well as the deep intestinal wall. And if there's enough gas, it actually precludes us from evaluating other deep intestinal segments. We oftentimes can't precisely localize the lesion because we can't follow the intestine from stomach to rectum continuously. And then some diseases like strictures and small ulcerations are nearly impossible to identify with ultrasound. Finally, it is an advanced skill and is very operator dependent. We have to be highly skilled, we have to be highly sensitive to identifying abnormalities, and we have to be very thorough. Sometimes we want to consider actually doing an upper GI series to know that we've evaluated the entirety of the GI tract and haven't missed anything. And we should keep in mind that not finding a lesion does not infer its absence. This slide just lists some common indications for ultrasound of the GI tract. Certainly things like vomiting or diarrhea, maybe weight loss and clinical signs. Sometimes we identify the obstructive pattern on radiographs, but prior to going to surgery, we might want to see what the cause is. Is it actually a wall lesion like a tumor, or is it a luminal lesion like a foreign body? Prior to endoscopy, we might consider ultrasounding, and that's more with the intent to make sure there's not a focal lesion that we couldn't reach with endoscopy, or maybe to see that the more diffuse lesion actually only affects the mid through distal jejunum, and that won't be able to be sampled with endoscopy either. First, let's talk about technique. In general, we would like to fast the patient as long as it's not medically contraindicated. That will keep our stomach empty and hopefully not very gassy. I also would like to consider sedating the patient if I'm not looking for GI motility. Sedation allows the patient to not be anxious and to relax, and allows for a more thorough examination of the GI tract. For most of my abdominal studies, I want to put my patient in dorsal recumbency like our example patient on the right of the slide. But we might want to consider positional imaging, maybe putting them in left side down or right side down, or sometimes even standing them and ultrasounding them, because that might move our luminal gas around, maybe give us some fluid so that we can improve imaging of various regions. You can see that our patient has the entire abdomen clipped prior to the study because the GI tract takes up the entire abdomen, and then we'll apply our acoustic coupling gel. As with any other body part, we want to choose the highest frequency transducer that we can. So I typically would like to have a greater than 8 megahertz frequency transducer. That, remember, is going to give us the highest detail and resolution, and that's going to be important when we look at intestinal walls. Now, we have a trade-off of losing penetration, and so our larger patients, large dogs, may require that we use a lower frequency transducer. For best general application, we'll use one of these convex or curvilinear probes. It tends to be tolerated better with a smaller footprint as well. We can get up under the rib cage and maybe get back even into the rectum under the into the pelvic inlet. However, the linear probes oftentimes give us improved imaging of the intestinal walls, one, because of the linear footprint, but two, because they are always higher frequency than the curvilinear probes. These two videos show us how we're imaging the ultrasound and then show us the abdomen of the patient and then show us the actual ultrasound. We might be able to actually image the GI tract continuously from the stomach to the colon. And you can see in my movie here, I am starting out on the stomach and I am transverse on the stomach, and then I am moving transverse down the the descending duodenum. Then I come across into the ascending duodenum. Now, my longitudinal and transverse planes in the GI tract will not necessarily correspond to the body patient planes. Now you can see I have to move, many different directions trying to follow all of those jejunal segments as they just kind of lazily curve around in the belly there. On the right side of the slide is an imaging movie that's showing the stomach in transverse, and then we can follow it into the pylorus, out into the duodenum. Watch that, sometimes as I'm imaging here, I'm on the transverse, and then I'm on the longitudinal. As I go down, I lose it a little bit, and then I have to come back. So I'm making all these small movements and changing up quickly, trying to make sure I don't lose it. Ascending duodenum, then I curve into a jejunal segment, and again, sometimes you'll see that I lose it and I have to go back again, and I'm not necessarily doing both long axis and transverse on any specific segment. Now, if I did identify an abnormality or if it was diffuse, I would stop and take those longitudinal and transverse plane images. Let's start out discussing some basic concepts that will apply across the GI tract, and we're going to start with the wall layering. So the wall of the GI tract has 5 individual layers which are sonographically apparent. The specific appearance and proportion does vary in different parts of the GI tract. I do want you to know these layers because we're going to use the layers and what they look like to help us identify normal from disease. And I'm going to start with the luminal area of the one intestinal wall and then move out to the serosa. So we have a initial mucosal surface luminal interface, which is typically very echogenic because of the luminal content. The first layer from the lumen of the intestinal wall is the mucosa, and that is a hypoechoic region of the wall. That is followed deep to it by the submucosa, which is a hyperechoic layer. That's followed by the muscularis, which is a hypoechoic layer, and then the most outer subserosa-serosa interface is a hyperechoic layer. So they alter as we go through. On this slide, on the left is a diagram depicting an intestinal segment. Keep in mind that I just gave you the layers of one wall, but certainly in the patient we'll see one wall, then we'll see the lumen, and then we'll see the other wall, repeating the layers we just talked about. Now this diagram shows layers but not in the appropriate proportion. So let's look at the actual ultrasound image of a corresponding segment of small intestine. In the center of this small intestine, which is kind of the outer margins indicated by the orange arrows, is the lumen, and that's really echogenic. So that's kind of our luminal mucosal interface. You can see this thicker hypoechoic band, which is our mucosa. And then deep to that is a very thin hyperechoic band, which is our submucosa. That is followed by a very thin hypoechoic band, which is the muscularis. And then the very outer area is a thin hyperechoic line, which is the serosa. And you can see that that is repeated on the other side. And in longitudinal axis, this looks like bacon strips to me. So that's how you might recognize your intestine. This is just the same intestinal segment with arrows indicating those layers we just talked about. This slide has two segments of jejunum in transverse, just so that you can see the layers in transverse. The one on the left obviously is labeled, and the one on the right you can look at without the labeling. So in transverse, here is our lumen in the center. That is our very echogenic area, so luminal mucosal interface. Then we have that hypoechoic area, which is the thickest portion here, which is the mucosa, followed by a thin submucosa that is hyperechoic, followed by a thin muscularis, which is hypoechoic, and then followed by the outer thin hyperechoic serosa. Now notice when we're not perpendicular to the intestinal wall, so out here on the edges, you can't see all of those walls. So we always get best imaging when we are perpendicular to that we are imaging. Here's an example of kind of a longitudinal image of the stomach, and this shows us that the proportion of the layer thickness is a little bit different in the stomach. When we look at this is luminal echogenic content. The mucosa and the submucosa and the muscularis are all similar in thickness, so still hypoechoic, hyperechoic, hypoechoic, and then the outer serosa here is again very thin. The duodenum looks like our kind of typical intestinal segment that we used, where the mucosa is going to be the thickest segment, or the thickest layer in the wall. So that is our hypoechoic mucosa. And then the submucosa, the muscularis, and the serosa are the very thin layers. And then this patient has a very echogenic lumen. We can't see the other deep wall very well because of some gas. Our segment of jejunum in the left of the slide here, you can see has a very similar appearance and proportion as the duodenum. So thickest mucosa and then thin submucosa, muscularis, and serosa. The colon has a little bit different proportion again. So we've got kind of luminal echogenic shadowing content. You can see that the hypoechoic mucosa, the hyperechoic submucosa, the hypoechoic muscularis are all similar in thickness. They're pretty thin, and then the serosa is very thin. We also should consider overall wall thickness of our intestinal segments, and this table gives you a listing which is compiled from several different references of different thicknesses depending upon which part of the intestinal area we are. So I have species, cat versus dog, and then dog is also various sizes of dog, and then we have stomach, the segments of small intestine, and the colon. I do not want you to memorize this, but you do need to have a general idea of thickness so that you can recognize if the intestinal walls are much thicker than these measurements. So if you remember that for a cat, most of the GI should be less than 3 millimeters. And if you remember that for a dog, most of the GI should be less than 5 millimeters, and that in both species the colon will also be the thinnest, that should be all you need to know for assessment in this class. In addition to being able to recognize the presence of our normal wall layers and then our normal proportions. So later on we'll talk about some layers being thicker than they should be. These are just examples of the different segments for thickness. So this is a longitudinal image of the duodenum in a dog, measuring thickness from the outer serosa to the inner mucosa. Typically, I want to measure this in transverse because it gives us the most accurate knowledge that we are certainly exactly perpendicular to the wall. But this patient has 4.3 millimeter thickness. These are transverse images of the jejunum, two different segments. One measures 2.8 millimeter, one measures 3.8 millimeter. This is a dog that's medium size, so this is okay. And then this is a longitudinal view of the colon. Again, measuring in longitudinal, transversal would be better, and you can see that that's only 1 millimeter, so quite thin. So now we want to move and talk about different parts of the intestinal tract and see how they might differ from other parts. So I'm going to use for each part as we move into a ventrodorsal view of a dog abdomen x-ray so that you can just kind of see where things are relative to other structures. So the liver here is going to be depicted in kind of a medium green. The kidneys will be in pink and the spleen will be in red. Right now we're going to talk about the stomach, which is depicted in yellow. And the stomach will be located caudal to and nestled up against the liver. Because of its location, especially in deep-chested dogs, the stomach is going to be oftentimes tucked up under the rib cage, which can make it challenging to image, and we oftentimes have to use an intercostal window. And because of its location, and also because it's oftentimes very gassy, a complete examination is not usually possible, especially hard to see the cardia, almost, some portions of the fundus, and then the pylorus. So we may or may not be able to identify that. The stomach has rugal folds, and if it is empty, we can see kind of this appearance of wagon wheel on transverse, and I'll show you an example of that. Wall thickness of the stomach can be difficult to assess, especially if you're not sure what's a rugal fold, because we always want to measure in between rugal folds. Here are examples of the stomach. On the left, we have the stomach kind of in a sagittal view of a dog. There is gas that has some reverberation and some shadowing in the lumen. Here is the ventral wall of the stomach. This would be a rugal fold. This would be a rugal fold. So if we're going to measure the stomach, we're going to want to measure in between the rugal fold. And again, we've talked about the layering and proportion already. Here's a transverse image of the fundus of the stomach in a cat, and this is that nice wagon wheel appearance that happens when the stomach is empty. So we can see rugal folds, and then we can see the kind of interrugal area. And then in the cat too, I'll just point out the submucosa can be quite hyperechoic and quite evident, because sometimes cats, especially if they're a little bit overweight, will put a lot of fat in that layer. So if we were going to measure the wall, we would measure it in this interrugal region. This slide shows the pyloric portion of the stomach. On the left, we have a dog. So this is a longitudinal view. We have some luminal content. When we get from the pyloric antrum toward the actual pyloric sphincter, one thing to notice is that the muscularis layer will actually get a bit thicker. So not a whole lot, but a bit thicker. So the hypoechoic outer muscularis layer. And that's because we're going into where we need the muscle for the sphincter. And then to the left of this image is the duodenum. Remember, the longitudinal view of the stomach is going to be actually transverse body plane of the dog. Here on the right is the cat. Again, we have some lumen of the stomach. As we get down towards the actual pylorus, so the orange arrows are depicting the actual sphincter, you can see that that hypoechoic muscularis layer outside of the submucosa is getting thicker, and then this is the duodenum. So that takes us into a discussion on the duodenum, and the duodenum is only distinguished from the jejunum on the basis of its connection to the stomach. So if you see, the duodenum has a cranial duodenal flexure, and then in the dog anyway, the descending portion of the duodenum is quite lateral. It's usually lateral and ventral to the right kidney. Then there will be a caudal duodenal flexure, and then the ascending duodenum is usually on midline. Takes a fairly straight course in both the descending and ascending portion. In the cat, because the pylorus is a little bit more toward midline, that will shift our descending duodenum over. Although the duodenal wall may be slightly thicker than the jejunal wall, when we look at the wall layering and proportion, the duodenum and jejunum are indistinguishable, and that's important to remember. However, in the proximal descending duodenum, we may be able to identify the duodenal papilla, and if we can actually identify the duodenal papilla, that would let us know that we're in the duodenum. So remember, the duodenal papilla is where the common bile duct and pancreatic duct will enter. So this slide does show the descending duodenum at the level of the duodenal papilla. This longitudinal image here shows us our normal wall layering and proportion on either side of an empty lumen. And then here's the common bile duct, pancreatic duct combination actually coming into the papilla. These are a little bit more echogenic, and if we sometimes see the papilla actually traversing the mucosa, it will also look more hyperechoic to the hypoechoic mucosa. This is a transverse image at the level of the papilla. So again, we can see our normal wall layering and proportion. And then here is a little transverse view of the more hyperechoic duodenal papilla. The ascending duodenum will look like the descending duodenum, obviously without a focal duodenal papilla. One variation that we might appreciate in the duodenum, and this is along the mesenteric margin or border of the duodenum, is something called pseudo-ulcers. These are lymphoid aggregates, and they will look, if we look at this longitudinal image of this duodenum here, there's some hypoechoic or almost anechoic fluid in the lumen. Here's our mucosa. They will look like these little square or maybe sometimes conical outpouchings that actually look like they are traversing the mucosa. You can see two in this patient, and these are normal. We don't worry about them, and we don't want to confuse them for, say, a pathologic ulcer. You will see them more frequently and see more of them in younger dogs. After the duodenum, we will see that almost the majority of the small intestine is comprised by jejunum. In our patient here, the jejunum is this light kind of green mess, and that's because the jejunum kind of moves throughout the entirety of the kind of abdomen. It is, as I said before, and this is an important concept, indistinguishable from the duodenum based upon wall layering. If we have fasted our patient, the jejunum should be essentially empty. However, if the patient is in a postprandial state, our luminal content will be variably echogenic. Usually fluid, may have some gas. We will see active peristalsis in stomach, duodenum, and jejunum if the patient has not been fasted. Here's a longitudinal view of a jejunal segment in the dog, and this is an image of 3 transverse plane images of various jejunal segments in the dog. And as we've already seen in our example, and as we talked about in the duodenum, we can see our normal wall layering and proportion. So again, lumen here, hypoechoic, thicker layer of the mucosa, thin hyperechoic submucosa, thin hypoechoic muscularis, and then thin outer serosa. Again, seeing that in both longitudinal and transverse. And I think I mentioned before that in longitudinal, I think the small intestine looks like bacon strips. I might have forgotten to mention that in transverse, I think they look like little hamburgers and hamburger buns. Here's just an example that shows a transverse image where we have the descending duodenum adjacent to the jejunum, and you can see that at this level they are indistinguishable based upon what layers we see and the proportion of layers that we see. When we measure this, the duodenum is just slightly thicker than the jejunum, but we could never use that to distinguish duodenum from jejunum. The last segment of small intestine is a very short segment, the ileum, and that leads to the colon. That's in purple here, so very short, leading to the colon. The ileum is distinguishable from the jejunum and duodenum based on the wall layering and proportions. The submucosa in the ileum is relatively thick, and the ileum has a lot of folds that can give it the illusion of more layers when we're looking at it. In transverse plane, there's a cloverleaf or Maltese cross appearance that I'll show you here. So here's a longitudinal image of the ileum in a dog. This is the colon over here. It's in transverse image in the ascending portion with some shadowing from the gas. Here's our longitudinal view of the ileum right down to the ileocolic junction. You can see that the submucosa is thick, as thick here as the mucosa, and then even our muscularis layer gets a little bit thicker. And then where there is no lumen, so here's a little bit of gas and content distending the lumen. Where the lumen is completely non-distended, it almost looks like there are multiple layers there in long axis. Here is the transverse plane of the, or transverse image of the ileum in a dog. This is the colon over here. You can see that the mucosa surrounded by the submucosa gives this appearance of looking like a 4-leaf clover or a Maltese cross, and then our muscularis is thicker here as we're getting closer to our ileocolic junction and the sphincter there. That brings us to the colon. The large intestine, that has both the cecum and the colon. So the cecum, once we identify that, will be more caudal to the ileum, and then the ascending, transverse, and descending portion of the colon are oftentimes able to be followed all the way down to the pelvic inlet. The cecum will be a blind sac, and then the colon will be able to continue following. The colon will appear very thin-walled compared to our small intestine, especially if it is distended, and then the wall layering is oftentimes difficult to identify. Luminal content is highly echogenic with dirty shadowing due to gas and any mineral content, unless the colon has just recently been evacuated or the patient has been fasting. Here's a longitudinal image of the descending portion of the colon in the dog. So here's all that highly echogenic content with reverberation and dirty shadowing, so some gas and some fecal material. The wall, the arrows are showing kind of the serosal margin. The wall, again, is quite thin compared to what we've already seen, and it is challenging in this patient to see the different layers. This is a transverse image of the transverse portion of the colon. And it's adjacent to a jejunal segment in transverse to give us that distinction between how thin this wall looks and how it is more challenging to identify the individual layers versus this jejunum where we have a little bit of luminal content and we can see good layering. The small intestinal content can vary depending upon whether the patient has been fasting or if the patient has been recently ingesting food. And there are 4 different patterns people will talk about. I don't want you to memorize this, but just so that you know what you might see as you're looking at ultrasound images. These are all in a dog. These are all longitudinal images. So this is a jejunal segment that is in a fasted patient. And so we just see minimal echogenic luminal content. When we see that, we call that a mucus pattern. We can easily see both sides of the wall. This is a patient that has more fluid in the jejunal lumen. So the lumen is actually distended. The fluid is not completely anechoic because it probably has maybe a little bit of digesta and a little bit of mucus in it. So it's kind of a complex fluid. And we can still see the more ventral and the more dorsal wall layer because there's no shadowing from the fluid. Notice that it does make the mucosa look a little bit hyperechoic here, probably from some acoustic enhancement. This segment has a gas pattern where there is a lot of luminal gas, a lot of reverberation and dirty shadowing. And so in this case, now we can only see the more superficial or ventral wall where we can still see all the layering, but we wouldn't be able to image anything deep to that gas. And then the final pattern is in a patient that has recently eaten. This is an alimentary pattern. There's a little bit of echogenic kind of fluid, digesta moving through. We can see the more superficial wall and the deep wall. And then the last thing that we should consider and that we can assess is peristalsis. On the left here, I have the stomach. If you watch this, you can see that there's a lot of materials this patient has eaten, and we can watch in that patient a lot of peristalsis that's occurring. I can measure contractions per minute, and in the stomach, a normal patient will typically have 4 to 5 contractions per minute. If I really want to measure them, I'm going to watch over several minutes. Here's a patient where we're imaging a longitudinal view of the jejunum, and this patient has also eaten. And as you watch, you can see as well some peristalsis. In the small intestine, contractions per minute are fewer, so 1 to 3 contractions per minute would be normal. If you are interested in maybe finding out some more information, both getting some more explanations or just seeing a lot more example of the various normals of the GI tract, please refer to these 2 textbooks that are listed in the syllabus, and here I've given you the appropriate chapters and pages for normal.